Thank you, and I hope you guys can hear me okay. Okay. So the first thing you need to understand is that this is a heterogeneous population of tumors, and they basically are named by the cell of origin. Okay, so there's, astrocytes, oligodendrocytes, neuronal cells, fibroblasts, arachnoid cells, on and on and on. All those different cells, if they grow inappropriately, that's what we call, primary brain tumors. Sometimes in neurology or neuro-oncology, we can tell what a tumor is just based on location. So, for instance, number one, astrocyte, these astrocytic cells, the most common cell in the brain, so that's a common area for astrocytic tumors. But then, if you come down here to 11, you see that's a paraganglioma, which is a common location for that type of tumor. It's also a common location for a myxopapillary epidemioma. So sometimes location can let you, or give you a hint as to where the tumor is located throughout the central nervous system. The most common gliomas, these are primary brain tumors made of glial cells, or glioblastoma, which is the most common malignant tumor. And then there's the grade 3 or anaplastic gliomas, anaplastic astrocytoma, anaplastic oligodendroglioma, and the mixed tumor type, which is called anaplastic oligoastrocytoma. Although when you look at the latest WHO criteria, a lot of people don't think there's such a thing as a grade, as an oligoastrocytoma, as a mixed tumor. And just a little aside, one of the neuropathologists there was an argument in the room, and when the neuropathologists were coming up with the 2016 WHO, some were arguing for it, some were arguing against it. Anyway, it's in there for now, but probably in the next iteration of 2016, there won't be such a thing as a mixed glioma. Sorry about that. Okay. And then there's low grade or grade 2 astrocytoma and oligodendrogliomas. Okay. So the histological classification is based on the predominant cell type. So you look under a microscope. If it's astrocytic, then you say it's an astrocytoma. If it's oligodendroglioma, if it's if it's an oligodendroglial cell, then you call it an oligodendroglioma, and on and on. And the grade is based on the degree of anaplasia, so loss of differentiation. And we use that to predict biologic behavior. Now, there's more that goes into it now. These slides are a little bit old because we use some of the molecular markers that I'll talk about a little bit later to also help us grade the tumors. But this has been the conventional, classical way of predicting how aggressively a tumor will behave based on what you see under the microscope. Okay. And so what I mentioned earlier about the degree of anaplasia, the dedifferentiation, that allows us to give a grading scale, and you can think of a grading scale as a malignancy scale. So there have been lots of other, lots of previous grading scales, but the one we use these days is the WHO, or World Health Organization scale. And like I mentioned before, this is a bit of an old slide, but now there's a 2016 WHO. So that's the one we use now to grade tumors. The others are historical interest if you ever kind of do work where you're looking at old papers. Sometimes you'll pull up an old paper and they'll say they used a Kernighan's method of grading tumors or a Ringert's, and so you just have to know how that correlates to the latest WHO. All right. So what do we look at under the microscope? For instance, with grade 2 astrocytomas, we look at the degree of hypercellularity and nuclear atypia. Those are the things that are required in order to give it the grade 2 designation. At a higher grade astrocytoma, we look at those other things that we saw before, the hypercellularity, nuclear atypia. But here, in order for it to be grade 3, we also have mitotic figures. And then grade 4 astrocytoma, which is by definition a glioblastoma, we have all those things that I mentioned, but then we also have endothelial proliferation and or necrosis. Okay. So histologically, here's a grade 3 astrocytoma or an anaplastic astrocytoma, and you see the hypercellularity, nuclear atypia, and if I wanted to go blind, that's probably a mitotic figure. Don't hold me to that, but there have to be mitotic figures present in order for it to be a grade 3. And then this is the grade 4 astrocytoma, or the glioblastoma, so it has all those other things that I mentioned, nuclear atypical hypercellularity, mitotic figures, and either necrosis or endovascular proliferation. And here's a pretty classic area of necrosis in this glioblastoma. So on tests and things like that, a lot of times what they'll do is they'll show a slide of this tumor. They'll give you a little kind of clinical, synopsis, and then they'll say, what type of tumor do you think this is? And they'll kind of put an arrow by the necrosis. And pseudopalisading necrosis is kind of the typical necrosis that you see with glioblastoma. If it's necrotic, then it can't be a grade 3, it can't be a grade 2. And that's the area of necrosis right there. So a little bit of epidemiology. If you look at all primary brain tumors, and this is from the Central Brain Tumor Registry of the United States, if you look at all primary brain tumors, then you see the most common primary brain tumor is actually a meningioma. Sometimes when I'm working with students or even medical residents in rounds in general neurology, I'll say, what's the most common brain tumor? And they'll almost always say glioblastoma. It's not true. The most common primary brain tumor is actually meningioma. The most common malignant brain tumor is glioblastoma. So meningioma is the most common, and then glioblastoma is the second most common. And this is just for primary brain tumors. If you ask the question, what's the most common intracranial neoplasm, that would actually be metastatic disease. All right, so now if you look at just glioma, meningioma isn't a glioma, so that comes out. So then you see here that glioblastoma is by far the most common glial neoplasm. By age group, it's sometimes cool to look at this. You see in kids, age 0 to 4, then medulloblastoma followed by polycystic astrocytoma. And then as you get to be an adult, you see meningioma, again, like we talked about, is the most common, followed by, glioblastoma. Another type of question that we often see on neurology boards or neuro-oncology boards is they'll put a picture, and this isn't fair because I don't have a picture of it, but they'll oftentimes put a picture of a pediatric MRI scan on the board, on a test question, and what they'll have is a posterior fossa mass, and they'll say, what's the most likely tumor? And then they'll give you a list. They'll say polycystic, they'll say medullo, things like that. One of the ways to differentiate, again, I hate that I don't have an image to show you, but a medulloblastoma tends to be a dark, enhancing posterior fossa mass, whereas a polycystic astrocytoma tends to have a cyst attached to it. So that's one of the ways you can differentiate. If they just kind of throw that picture up there and say which one in a 4-year-old patient, it's probably going to be a medullo. Statistically, as well as imaging, you can figure that out. Okay. So in neuro-oncology, just like in neurology, everything is kind of real estate. So the presenting symptoms are oftentimes based on the location of the tumor in the brain. So for instance, a left frontal tumor is likely to present with somebody losing their speech and having right-sided weakness. A left temporal tumor is likely to present with somebody having speech difficulty, and on and that, like that. The acuteness of it also helps. People with strokes have something with rapid onset, whereas people with tumors generally have things that kind of come on slowly over weeks or months. There's nothing that says this is definitely a brain tumor, Okay. Alrighty. And just so you understand how a brain tumor causes symptoms or causes damage to the patient, mass effect because of increased intracranial pressure, which is either directly due to the tumor or due to edema. And then there's actually infiltration or destruction of the normal brain tumor. So those are the two ways that the tumor can cause problems that the patient presents with. So signs or symptoms are about what you would expect: headache, nausea, vomiting. But headaches are much more common and usually not associated with brain tumors. So I don't think of somebody, this person has a headache, we've got to get an MRI scan because they may have a brain tumor. It's more common to have a headache for a reason other than a brain tumor than it is to have a headache because of a brain tumor. But change in personality, mood, mental capacity, concentration, psychomotor slowing, all those things can be potential signs and symptoms of somebody with a brain tumor. Okay, I'm going to skip that. All right. Interestingly, seizures can be, not surprisingly, a presenting symptom. I spoke a minute ago about the grades of tumors, and believe it or not, the lower grade the tumor, the more likely it is someone is going to present with a seizure. So a grade 4 astrocytoma or glioblastoma, there's like a 1 in 5 chance that you present with a seizure. Whereas once you get down to grade 3 and grade 4, there's kind of a 50% chance that you present with a seizure. And the thinking there is that because the lower grade tumors are so slow growing, they have more of a chance to kind of cause cortical irritation, whereas the higher grade tumors are so fast, you're more likely to present with a deficit, a motor deficit. Okay. So imaging, this is how we generally look for brain tumors is by getting MRI scans with and without contrast. And here we have a axial T1 post-contrast MRI scan. And this is a pretty classic picture for a glioblastoma. So what we have is a irregular border, heterogeneously enhancing mass lesion. It's usually one mass lesion as opposed to METs, which can be multifocal. This is unifocal. Here you can see a little bit of mass effect with this tumor pushing from the right to the left, a little bit. So that's a pretty classic picture. And these hypo-intense areas in the center tend to be associated or correlated with necrosis. All right. Here's a sagittal T1 post-contrast, irregular border, single lesion with mass effect, and then just to kind of beat a dead horse, again, a lesion here, again, irregular border, single lesion, and this dense stuff around here, hypo-intense, in the tumor, necrosis, but outside the tumor, that's commonly edema, so swelling associated with the tumor. So how do we treat these tumors? Well, it's generally, 3 modes of treatment. Surgery, we try to achieve the best surgical resection possible, which means essentially taking out as much tumor as we can, but leaving the patient intact neurologically. Okay, so no one wants to achieve a complete resection of the tumor and leave the patient debilitated. For instance, a left temporal tumor, you're not going to resect the whole tumor and leave the patient with a speech deficit. That's why we do things like awake mapping. Have the patient awake and you talk to them during surgery. And when you stimulate a certain area of the brain, if that area of the brain causes them to lose speech, then it's not safe to take that. If you stimulate that part of the brain and it doesn't affect their speech at all, then it's safe to take because it's a non-eloquent part of the brain. So surgery is essentially maximal safe resection, and that's the goal of any place you go in the country. And then radiation treatment is usually next, which is involved field radiation. It's not whole brain for primary brain tumors. Generally over 6 weeks of therapy where they give a fraction a day. And the standard dose these days is 60 gray. And there have been lots of years of research trying to increase the radiation dose through different methods. And it seems like 60 gray of focal radiation is the best that we can do. At least that gives us the best clinical result. All the other types of iterations or manipulations that we've done with radiation haven't really improved clinical outcomes. And then lastly, there's chemotherapy. The drug we use, at least for newly diagnosed glioblastoma patients, is a drug called temozolomide or Temodar. It's an alkylating agent, a methyl alkylating agent if you want to be specific, and it's oral. So essentially what patients do is take the chemotherapy with their radiation. Usually after radiation is completed, they get a month break and get an MRI scan, and then they'll continue on with Temodar chemotherapy after the radiation is complete as maintenance or adjuvant chemotherapy. So those are the 3 arms of treatment for glioblastoma. And any place you go, any textbook you open, that's pretty accepted as a standard of care. Okay. So primary brain tumors rarely disseminate outside the central nervous system, so we generally don't stage patients. That's a common question I get in clinic. Somebody comes in with a glioblastoma and they'll say, well, do I need to get a PET scan to make sure it's no place else? And I tell them no. We don't really stage because they don't go anyplace else. Now, obviously, there's nothing in medicine is 100% of the time. So sometimes they do, but that's really, really, really unusual. And I think in all the years I've been doing neuro-oncology, I've only seen 2 glioblastomas that have ever metastasized outside the central nervous system. A lumbar puncture we don't do, and I'm talking about for primary gliomas. They can be helpful for epidemiomas. They're absolutely critical for a lymphoma, for primary CNS lymphoma. Medulloblastomas in kids, you tend to do LPs. And it just has to do with the staging. So using lymphoma as an example, I tend to think, and I'm not the only one who thinks so, that there's no such thing as a primary CNS lymphoma that's just in the brain. I think if you have primary CNS lymphoma, then it's basically throughout the neural axis. And they've done autopsy studies where they've looked at patients, and essentially when they sample the CSF, almost 100% of them have lymphoma cells in the leptomeninges, or the CSF. So whether it starts there or not, I think that you have to consider lymphoma a central nervous system disease throughout the axis. And it's good to know exactly where the disease is before you start treating patients. Because when you assess them later to figure out how effective your treatment has been, you're going to want to check all those areas where the tumor was, before treatment began. So staging for lymphoma, including an LP, I think is pretty important, but not for the other types of primary gliomas. It's good to have patients treated by a multidisciplinary team. And who's included in that multidisciplinary team is general neurosurgery, radiation oncology, and neuro-oncology. A common question I get is steroids, and people who don't take care of people with brain tumors really don't know how much to use steroids. Now, what do we use steroids for to begin with? Steroids are basically a medicine given to reduce symptoms associated with the brain tumor. It's not therapeutic in any way. It basically helps diminish or decrease symptoms associated with brain tumor swelling. And I should emphasize that. I showed you on the MRI scan a little while back how there was that little area of hypointensity anterior to the enhancement. Well, that was edema. Sometimes you can have a lot of edema. And when you have a lot of edema associated with a brain tumor, then that edema can cause patients to be symptomatic. And by giving a patient steroids, you basically decrease the amount of edema. And then, in turn, decrease the symptoms associated with it. So, common scenarios, somebody comes in with an MRI scan, there's some edema there, but they're completely asymptomatic, and a resident will call me, should I put him on steroids? Well, is he symptomatic? No. Then the patient doesn't need to be on steroids. Another common scenario, a patient is basically due for an MRI scan, and they've been getting worse. Say it's a left frontal tumor, and they've been getting right-sided weakness over the past several days. They call in because they're getting weak. And like I said, they're due for kind of a follow-up MRI scan. I'll say, well, probably we need to start you on your steroids. Okay, well, how much should I take? Sometimes I've seen around here people will start very high doses, like 16 milligrams a day, 4Q6 or things like that. In general, people who take care of brain tumors like myself regularly don't ever go up to doses that high. I consider a high dose 4 milligrams twice a day. That's a lot of steroids to me. If I think someone's mildly symptomatic and I just want to start them on something to see if they recover, then I might do 2 milligrams twice a day or 3 milligrams twice a day. Go ahead. Yeah, we're talking about dexamethasone. I should have said that. And basically any steroid causes that reverse edema. The reason we use dexamethasone is just by convention. But prednisone would do it, all these other things. There's less of a mineralocorticoid effect with Decadron. And so years and years and years ago when we started using steroids for brain tumors, everybody just said, let's use Decadron. But that's what we use. So, and you're right, because the dose would be different. Obviously, if I said 2 milligrams of BID for prednisone, that'd be, right, not appropriate. So Decadron is the dose is what I'm talking about. Dexamethasone. So a non-symptomatic patient doesn't need to be on steroids. A symptomatic patient can be started on a low dose of steroids. And for me, it's continuous taper. I'm always trying to get them off or keep them on the lowest minimal dose that's effective. So this example of a patient that I use who gets started on steroids, we put them on, say, 2 milligrams BID. They call me back 3 days later and they say they're better. I might leave them on that dose for a week and then try to taper them off, usually by decreasing it by 1 milligram a week. And then I'll tell them, generally, if you get weaker after a week or a few days, then just go back to the last dose you were stable on. But at least I know that's the dose that you need. You know, if we go down 1 milligram and you're okay, well, that's fine. Then another week later, we'll try to decrease it again. So it's a continuous taper. Like I said, I never use 16. 8 is a lot for me, and I'm always trying to go down lower. And generally, if there's going to be a benefit, you usually see it in 3 days. And generally, if there's going to be a decline in their clinical symptoms, you'll usually see it in a few days. And then I just tell them to go back to the dose that they were stable on. But that's what we use. So, and you're right, because the dose would be different. Obviously, if I said 2 milligrams of BID, they call me back 3 days later and they say they're better. I might leave them on that dose for a week and then try to taper them off, usually by decreasing it by 1 milligram a week. And then I'll tell them to go back to the dose that they were stable on. Okay. I spent a lot of time on that because I just see crazy steroid dosing around here.
Well, where did that idea come from, though?
Using steroids?
Well, using those really high doses. Because typically, you'll see 6 hours. And, and I usually take care of frail old people. A lot of times they get delirious.
Mm-hmm.
But that idea had to originate somewhere. It's very...
Yeah, it's very... And I don't know. That's a good question. I don't know. But I mean, I see it everywhere, up to date, things like that.
That's what we see, like the neurosurgery residents doing, like in the...
And I've talked to them time and time again. And they say, well, if you want us to change it in up to date. Okay, great. So anyway, I don't know why, but really you shouldn't be using that high of a dose. And I've seen people discharged from Frazier on 40 milligrams a day. Whew. Okay. Alrighty. All right, so I'm going to kind of speed up through this because we talked about this. That treatment protocol I talked about with radiation, concurrent temozolomide, followed by adjuvant temozolomide, that was based on a phase 3 randomized trial. And the lead author was a guy named Roger Stoop. It's spelled R-O-G-E-R, but he pronounces it Roger, and he'll get mad if you call him Roger. Okay, so the Stoop protocol, which was published in Lancet Oncology, and basically, that was a randomized trial where newly diagnosed patients with glioblastoma after surgery got radiation or got radiation with concurrent temozolomide followed by adjuvant temozolomide. And in this arm, the experimental arm, the median survival was about 14 months. And the control arm, the median survival was about 12 months. So that became standard of care, the so-called Stoop protocol. And you'll hear that kind of a lot. Maybe you won't, but if you're a neuro-oncologist, you hear it all the time. Okay. A little bit about seizure medication. Patients with primary brain tumors only go on seizure medications if they've had a seizure. Okay. So if they've never had a seizure, you don't need to put them on seizure medication. We've had 3 prospective randomized trials that tell us adding seizure medications to someone who's never had a seizure doesn't change the risk. Okay. So sometimes we'll have neurosurgeons here who'll put someone on a seizure medication prophylactically or kind of perioperatively. And then when I see them in clinic, I'll ask them if you ever had a seizure. I'll kind of explain the risk benefits of being on a seizure medication versus the likelihood of them having a seizure, and then taper them off the seizure medication. Now, if they've had a seizure, then they should absolutely be on seizure medications because that does change the risk. Okay, so that's another pet peeve of mine: steroid dosing and seizure medication. If they've never had a seizure and they have a primary brain tumor, they don't need to be on a seizure medication. The risk is only about 2 to 3%. If they've had a seizure, then they need to be on a seizure medication. The agent that we use most commonly is Keppra, levetiracetam, Keppra. Back in the olden days, we used to use Atlantin, but some of the newer chemotherapy agents were these liver-activating enzyme drugs. And so combining those with Dilantin would cause us to use these really high doses of chemotherapy. So then when Keppra came out, we started using that so we wouldn't have to adjust the dose of chemotherapy. And it's kind of stuck. So it's a oral, twice a day drug, the Keppra I'm talking about. And normally what I'll do is I'll start a patient on 750 or 1,000 milligrams twice a day. And they generally do okay with that. Sometimes if people have psychiatric history, then being on the Keppra can cause them to have an exacerbation that way. Personality change, things like that. So that happens sometimes. I'm a little less likely to do that if there's some strong psych history. A thing I warn patients about also is sleepiness. Being on these seizure medications can sometimes cause them to feel a little sleepy, but generally that goes away after a couple of weeks if they've been on it long enough. But it's pretty well tolerated. It generally doesn't interact with any other medications. And if they've had a seizure, I kind of load them 1,500 milligrams of Keppra and then start them on some mid-range dose BID. Okay, I'm going to skip that part. What I'm skipping over is just the trial, that Stoop protocol. And maybe I should kind of talk about this because one of the things they noticed in the trial was that there was a certain gene product called methylguanine methyltransferase, or MGMT for short. Now, methylguanine methyltransferase, specifically 06-methylguanine methyltransferase, is a protein that antagonizes the methylating effect of the temozolomide. Essentially what it does is it plucks off the alkylating agent from the DNA that the temozolomide is placed. Remember we talked about temozolomide as an alkylating agent, which means it alkylates the O6 position of the DNA, O6, the guanine, 06 guanine, and the MGMT, methylguanine methyltransferase, basically takes away that alkylating agent, or the alkylating group, I should say. Now, obviously, if you have that there, you're giving chemotherapy, the MGMT is counteracting that. What do you expect from the patients? So patients who produce MGMT tend to do worse than patients who don't. And how the MGMT is silenced or activated has to do with methylation of the promoter region. So if the promoter region is methylated, that means there's no production of MGMT. That means there's nothing there to counteract the temozolomide. So methylated MGMT is good. Okay, if it's unmethylated, that means you're producing MGMT, which is counteracting the chemotherapy. And so unmethylated MGMT, for our purposes, is bad. All right. So in this study, they wanted to see what the predictive and prognostic impact was of the methylation status in patients with glioblastoma. So those, this was the enrollment criteria about the STUDE protocol. The patients were the same in each arm. This is how many patients they had in each arm, over 200. And I already told you about the survival. This was the combined modality and this was the radiotherapy. So you can see the survival curve was improved when you added chemotherapy. And then when you look at methylated, again, shutting off MGMT production and unmethylated, and you look at the curves here. So patients who were treated with radiation and chemotherapy did a lot better than patients who got radiation alone. So the obvious conclusion here is that the methylation status in these tumors was prognostic, because even when you didn't add chemotherapy, this radiation arm alone was better than this. But it was also predictive in the sense that when you add temozolomide chemotherapy, you see the survival curve, improve. So that was kind of a big deal if you're a neuro-oncologist. And then patients kind of got online, started Googling it, and then one of the first things they wanted to know is, what's my methylation status? Should I take Timidar chemotherapy? Because, according to the, yada yada online, they're saying I'm not going to respond to Timidar. And what I like to point out to patients in a way I hope they can understand is, even in unmethylated MGMT, with combined therapy, there's a longer tail. So clearly the survival curve isn't as robust as with methylated MGMT, but there are some patients that respond in spite of the unmethylated status when you add Timidar. So I use that as a reason to take the chemotherapy anyway. And I think the risks are low or minimal. So we talked about the survival, radiation temozolomide, 14 to 15 months. Radiation alone was about 12 months. I'm just going to show you about the methylation status. So MGMT unmethylated with combined therapy, the median survival was about 12 or 13 months. When you look at methylated with combined therapy, the median survival goes up to almost 2 years. Okay. I like to point that out because a lot of times with glioblastoma, folks have a nihilistic attitude, especially in the community. You've got a glioblastoma, I wouldn't do anything, I'd take a boat to Hawaii or whatever the case is. And I've got 71-year-old patients who are out 4 years now. So one of the things I emphasize to patients is that when we talk to them about prognosis, and anybody who does oncology knows this, we can say what happens to 100 patients, but we can never say what happens to one. So I like to give them a good idea of what to expect, because they need to know it's a very serious thing. No one wants to walk out and think, well, if I've got 12 months to live, potentially I'm going to want to change some things possibly. But I try to leave them with that sense of, here's what we're up against, but you could possibly do better, and leave that hope there. So I hate it when I talk to patients, and again, it's another pet peeve of mine. I got 3 of them. So I hate it when I talk to patients and they come in and they say, well, this doctor said I only have 12 months to live. Like it's written in stone. No one knows. So understand it's a serious tumor, but no one can throw a dart at a calendar and say this is how long you have to live. Can't do it. Okay, so this is the treatment that I outlined. The temozolomide with the radiation, we give a month break, and then we follow it on with temozolomide afterwards. During radiation, this is again the Stoop protocol that I kind of alluded to. 6 weeks of radiation with daily temozolomide, and then the break. And then after we finish, it's a different schedule. It's a different course. Then it's 5 days on, 23 days off, which is one cycle. This protocol actually stopped at 12 cycles, but before this trial result was released, by convention, a lot of neuro-oncologists treated patients after radiation for a year. Without there being any data, it was just one of those things we just did. And so when this came out, some people started going to 6 months of maintenance therapy. Some people stayed at a year. You know, I don't know what's right. There's never been a randomized trial. Okay. I'm going to skip that part since you're not a neurologist. Okay. We talked about edema. Okay, here's a good thing I want to mention. This is actually a metastatic brain tumor here. The hypointense area there, that's edema, okay? And you can imagine how symptomatic a patient would be from that much swelling associated with the tumor. Start them on steroids, decrease edema, symptoms generally get better. Now, well, I guess that's the same thing. Still edema surrounding the tumor from a MET. METs tend to have this inordinate amount of edema surrounding them. Okay. I don't know why I'm beating edema. So this is a talk I normally give to neurology residents, so I wanted them to understand about edema.
If you think your patient is radiating, what's the best thing to do quickly before you get them stabilized in the ICU? Okay,
that's an excellent question. So a good thing to understand is, okay, the story I give neurology residents is increased pressure, increased mass effect. One of the headaches that's classically associated with brain tumors is the morning headache. So people talk about, well, what's your headache like? Is it worse in the morning? Yeah, okay, well, that's associated with the brain tumor. Well, why is that? You know, why is a morning headache considered a worse, considered to be one of those things we associate with brain tumors? The reason is because when you're sleeping at night, you're lying down and you're breathing slowly and shallowly. I think that's a word. So that causes increased intracranial pressure. Can anybody tell me why? Say again? Exactly. So you increase CO2, which means vasodilation, and also you're lying flat. Okay? There's no natural, it's not like in your legs where you have these muscles kind of causing blood flow, return. In the brain, it's basically all gravity driven. So you're lying flat, you're breathing shallowly, so there's decreased flow out, and you are vasodilating because you're becoming hypercapnic. Increased CO2. So when you wake up, blood flow, and then you start breathing faster, decreased CO2, vasoconstriction. If you know that, then you know immediately what you want to do when somebody comes in with with evidence of increased intracranial pressure. What we do in neurology is we basically put them in a bed, elevate the bed, intubate them, if it's that serious, and start hyperventilating the patient. So those are very quick things to do. Okay, they don't last very long. That's not something you can do to cure a patient forever. But it gives you, it buys a little time. It gives you an hour or two until you move on to the next thing. Now, when you're talking about brain tumors, the next thing is steroids. Okay, we don't use mannitol. Or let me take that back. We don't, use hypertonic saline and things like that for brain tumor edema. Hypertonic saline works for cytotoxic edema, like with strokes and things like that. But in order for hypertonic saline to work, you need a intact blood-brain barrier, and that's gone with brain tumors. So essentially it can exacerbate a problem. It can make it worse. So we use steroids. That's the next best thing. And then finally, the last thing, depending on the clinical scenario, et cetera, is surgery, to remove the offending mass. So they come in, start them on steroids. If it's bad enough, elevate the bed, hyperventilate, and give them steroids and wait for the surgeons to kind of do their thing.
I know you said that when people come in, you don't like to say that you're going to die in a year. Mm-hmm. But do you address that, that this will likely end their life?
Absolutely.
And how do you bring that up, and what do you do for them?
So every family's different, but in the broadest sense, I generally kind of tell them, I educate them as best I can about the tumor. And almost invariably, the patient or the family will say, well, how serious is this? Or another common question is, well, is this cancer? And basically I'm saying, well, what does cancer mean to you? Well, it means it's something I can die from. And so then I'll kind of go into the conversation that way. And my emphasis, and sometimes depending on how overwhelmed they are the first meeting, I may not talk about it then. I may wait until I establish a better rapport with them and then bring it up next time. But I don't want to go too far into my relationship with them without them knowing how serious it is. I always tell patients, here's kind of what we expect with a lot of people, but there's always a range. These things are like bell curves. There are people that don't do as well and there are people that do really, really well. And I don't know where you're going to fall in that bell curve. If we were like all common, a thing I tend to like to do is and say if you were typical, because no one likes to be typical. Everybody wants to be atypical. So I say, well, if you were typical, then you might die within this time. Well, I'm different. And it kind of gets a patient thinking more in terms of how they can be optimistic, about their therapy, things like that. So that's how I do it. Everybody has their own style. Yeah. Mm-hmm.